All right, so this is the last lecture of Unit 6, and it's actually the last lecture of the Biochemistry course here at Da Vinci Academy. So for this last lecture, we'll talk about neurocutaneous syndromes. And the first one we'll talk about is Neurofibromatosis Type 1, also known as von Recklinghausen disease. And it's due to a mutation in the NF1 tumor suppressor gene on chromosome 17. That can sometimes be a test question, what chromosome it's located on. And then tumor suppressor gene should immediately tip you off to that these patients are at risk for cancer. And they certainly are at risk for certain types of cancer. And we'll talk about that in a second here. Remember, tumor suppressor genes are really responsible for keeping the cell cycle and keeping cell division in check. And when they're mutated, unfortunately, cell division can continue completely unchecked, and that's how you develop cancer. So the gene product of NF1 is called neurofibromin, which is a GTPase activating protein, which regulates the RAS oncogene and the RAS signaling pathway, which is involved in cellular proliferation. And it's actually a negative regulator of RAS. So if you lose neurofibromin, the RAS pathway can then continue on unregulated, and that results in increased cellular proliferation, and that again results in cancer. About half of the cases of neurofibromatosis type 1 are due to spontaneous mutations. The other half are inherited. For those that are inherited, they have a nearly 100% penetrance, and they demonstrate variable expressivity, meaning that there's a very long list of symptoms and clinical findings that can be seen in these patients, and it's just very variable. There's no standard, set of 3 symptoms or 3 clinical findings that every patient will definitely have. It's very variable, and so that's essentially what we mean by that. For those that do inherit it, it's an autosomal dominant inheritance. This is considered a neural crest cell disorder. As far as the clinical features go, you can see certain neurofibromas in the skin, Lisch nodules, which are these brown spots on the iris of the eye. As far as tumors go, you can see pheochromocytomas, optic nerve gliomas, and then you can also see astrocytomas, which is a type of brain tumor, a type of glioma. You can see nerve sheath tumors. And then you can also see neurofibromas. And then also, lastly here, we say you can see cafe au lait spots, which are shown in the picture here, which are these sort of lightly coffee-colored patches of skin like this, and these are very characteristic for NF type 1. The other thing that the vast majority of these patients deal with is both cognitive and then learning disabilities. And it's both children and adults that deal with these. And some examples of those are ADHD, and then some even deal with autism as well. And then another thing I'll mention that these patients can also have are skeletal deformities. And you can see those both in the face and long bones. So keep that in mind as well. But definitely these cafe au lait spots, brain tumors, optic nerve gliomas, these Lisch nodules, definitely high yield things to be fine. And these other things are also definitely possibilities as well. And then as far as clinical management goes, you really just treat what symptoms they're exhibiting. So neurofibromatosis type 2 is a mutation in the NF2 tumor suppressor gene on chromosome 22. And you can remember that, type 2, NF2, chromosome 22. And the gene product of NF2 is Merlin protein or schwannomin. And this is a protein that regulates cellular proliferation. And some pathways that it impacts particularly are the P21 and RAS pathways, among others. Those are just the 2 notable. And as a mutation in a tumor suppressor gene, just like with type 1, it puts these patients at risk for certain types of cancers. The inheritance for type 2 is autosomal dominant, and just like type 1 also, it's a neural crest cell disorder. This disease particularly affects the nervous system, so you can see cataracts in the eyes, and then bilateral, and I apologize, this should really say vestibular schwannomas, so make sure you correct that in your book, bilateral vestibular schwannomas. And schwannomas are tumors that arise from Schwann cells, which are cells found in the peripheral nervous system that provide support and actually produce the myelin for peripheral nerves. And the reason it's called vestibular schwannoma is because if you look here, again, this is an older diagram. It used to be called the acoustic nerve. Now it's called the vestibular cochlear nerve, which is also known as cranial nerve 8. So it's one of the cranial nerves. And so vestibular schwannomas are tumors that arise from the Schwann cells around the vestibular cochlear nerve. Now, what's interesting, if you remember your anatomy, this opening here is known as the internal acoustic meatus. And this is a foramen in the skull base, and it's also where the facial nerve exits the skull base as well. So this is cranial nerve 7. So these two travel together. So these patients, they'll present with hearing loss because obviously cranial nerve 8 is responsible for hearing. They'll also can have balance issues, and then they can also present with unilateral facial paralysis because this tumor can grow to the point where it impinges on the facial nerve, and they can present with those symptoms as well. In the general population, if this just happens spontaneously, it's usually on one side. However, patients with type 2 are very often found with bilateral vestibular schwannomas, meaning they have a tumor on each side. So again, the rule of twos here, type 2, NF2, chromosome 22, and then they'll have 2 vestibular schwannomas. So another distinguishing factor to remember this disease by. In addition, these patients are also at risk for meningiomas, which are benign tumors that arise from the meninges, which is the connective tissue covering around the brain and spinal cord. And then they're also at risk for ependymomas, which are tumors that arise from the ependymal cells found within the central nervous system. So again, another type of brain tumor. As far as treatment goes, these patients very often have to see a neurosurgeon to have these tumors surgically removed. And then beyond that, whatever symptoms they also exhibit will be treated as well. So von Hippel-Lindau disease is due to the deletion of the VHL tumor suppressor gene on chromosome 3, and specifically, VHL inhibits hypoxia-inducible factor 1 alpha, which is abbreviated as HIF1 alpha. So let's come down here and draw the sequence here. So VHL is over here, and it acts to inhibit HIF1 alpha and keep it in check. So HIF1 alpha specifically, it stimulates the production of 2 different molecules. So first, it stimulates the production of vascular endothelial growth factor, which stimulates angiogenesis, which, as you can guess from the name, is the production of new blood vessels or new blood vessel formation. The other thing it stimulates the production of is erythropoietin, or EPO, which stimulates red blood cell production in the bone marrow. The problem is if you have lost VHL, you lost this checkpoint or regulation of HIF1 alpha, so it's dramatically increased, and then you have increased levels of VEGF and increased erythropoietin. And as we say here, increased erythropoietin can lead to secondary polycythemia. So polycythemia, whether it's primary or secondary, is increased hematocrit, or increased concentration of red blood cells. The problem is if you have increased concentrations of red blood cells, that can put you at risk for hyperviscous blood, which can then also put you at risk for developing a thrombosis. And so this would be an example of a paraneoplastic syndrome, where a tumor is secreting erythropoietin and stimulating a secondary polycythemia. So let's go back up here and go through the rest of the text. The inheritance is autosomal dominant, and then the clinical features here are specifically bilateral renal cell carcinoma, so on both sides, pheochromocytoma, which is a tumor of the adrenal medulla, and then hemangioblastomas, which are tumors that are composed of endothelial cells. So they're essentially vascular tumors. They're complex bunches of blood vessels, and specifically, they're typically found in the central nervous system. So they can really occur anywhere in the spine, the brain, or even in the eyes. And the thing is since they're composed of endothelial cells, the problem is that HIF1 alpha, acting completely unregulated because of the absence of VHL, by stimulating VEGF and erythropoietin, it stimulates the production and the growth of hemangioblastomas. Additionally, here you can have vascular malformations, including cavernous hemangiomas in multiple different organs. And cavernous hemangiomas are just benign vascular tumors that you can find throughout the body. And then a mnemonic to remember this by is BPH, bilateral renal cell carcinoma, pheochromocytoma, and then hemangioblastomas. Treatment for these patients is for any one of these tumors, you're going to have surgical removal, even for hemangioblastomas. Hemangioblastomas are typically benign, and they have a low occurrence of actually bleeding. But the problem is they can grow large enough, they can cause mass effect in either the head, by impinging on the brain, or in the spine by impinging on the spinal cord, and can cause secondary severe neurological problems. And so it's to the patient's advantage, if they're growing at a abnormal rate, is to have them removed. So we'll finish this lecture out by talking about tuberous sclerosis, which is a pretty rare disease in the general population, but it shows up a lot on exams, and so you definitely want to be aware of it. So it's due to mutations in the TSC1 and TSC2 genes, which are both tumor suppressor genes located on chromosome 16. Specifically, TSC1 encodes the harmatin protein, and then TSC2 encodes the tuberin protein. And again, these are both tumor suppressor genes, and beyond that, you don't really need to know anything more. Inheritance is autosomal dominant, and then they have a lot of unique clinical features, and the fact that these tumor suppressor genes are impacted, they develop a lot of unique tumors that are really rare in the general population, but very common in these patients. So hemangiomas, they're definitely at risk for these. These are benign malformations of cells. They can resemble tumors, so patients are at risk for these. They can be found in different areas throughout the body. Angiofibromas, which are very characteristic for tuberous sclerosis. And these are sort of like a rash of reddish bumps, especially found on the face. Very characteristic for tuberous sclerosis. They can be in that butterfly distribution. These patients are also at risk for rhabdomyomas in the heart specifically. This is a very rare tumor, again, in the general population, but very common in patients with tuberous sclerosis. Very commonly found in the ventricles of the heart. They're also at risk for angiomyolipomas, which are tumors found in the kidneys. And just to break the name down here, it's a collection of angio would be vascular cells, and then myo would be muscle cells, and then lipo would be fat. So it's a tumor composed of vascular, muscle, and fat cells, and then oma is just a mass, if you recall from pathology. And so patients are at risk for developing these as well. The vast majority of these patients, unfortunately, have to deal with neurocognitive and behavioral difficulties. So they can have intellectual retardation. As we say down here, they can develop autism spectrum disorder. They can also be at risk for ADHD, anxiety, and can be prone to developing depression as well. They're also at risk for developing seizures. And they have a lot of unique skin pathologies or skin lesions that you can see. And these are very commonly mentioned on exams. Sometimes you'll even see a picture of them on exams. So first, shagreen patches. And shagreen patches are areas of thick, leathery skin, and they're dimpled, kind of like an orange peel or a lemon peel. And then you have ash leaf spots. These are also very characteristic for tuberous sclerosis. These are light pigmented patches of skin, and they're caused by a lack of melanin. And then you also can see in these patients ungual fibromas, which are sort of skin-like tumors that are found under the toenails or the fingernails. Patients are also at risk for developing subependymal or giant cell astrocytomas, which are a type of brain tumor. And then they're also at risk for developing mitral valve regurgitation. All right, so that closes out our discussion of neurocutaneous syndromes. It also closes out Unit 6, Systemic Disorders, and it also closes out the biochemistry course from Da Vinci Academy. Thanks for watching, and best of luck to you.